Opioid Partnership. And we're really excited about today's presentation. We often do trainings about pharmacology and like the how-to, the evidence behind buprenorphine, but we're excited that today's 2-hour session gives us an opportunity to address the questions that we have experienced over and over again while trying to implement pathways to start medications for opioid use disorder in emergency departments. And so here today to help me is Ariana Campbell with the California Bridge Project, and I'll have her introduce herself in a second. We have Andy King from DMC and Kat Kaneda, who is going to be helping us in the chat in dropping resources that we'll share afterwards. Ariana, do you want to expand on your introduction, and then we'll move to Dr. King afterwards?
Sure. Yeah. So I'm Ariana Campbell. I'm a PA. I work in an emergency department in Northern California, the foothills. It's a small, a rural emergency department. And I started a program 5 years ago that actually was pretty easy and very, very effective, and became a very passionate advocate for others to do the same. So I'm one of the co-founders and co-principal investigators of California Bridge. And we've implemented so far in a couple hundred hospitals in California, working on 100 more. And we're also working with 40 states with just really passionately trying to get the word out there, because and we'll talk about today some of the barriers that we face, some things that came out of my own mouth when somebody told me that I should be doing this in the emergency department. I did a self-assessment and realized what I was doing I wasn't proud of. So I made a change, but some of the stuff we'll talk about here has been said by probably any number of us when somebody told us we should be giving buprenorphine in the emergency department. And also we've heard this from other people, of course, when we've been talking about the best practices and the best ways to treat opioid withdrawal. So, all right, Andy, I'll turn it over to you.
Oh, definitely. Thank you very much for the handover. And we're also drinking coffee. Ariana, but we both got it going on. And I like this. I'm excited about doing this presentation too, because I enjoy having the conversational style of this, being able to dispel the myths that are out there and address the questions that we've heard, like she said, many times in the past, and things that we probably even thought of and said ourselves. But I'm an emergency physician too. I work here in Michigan and at the DMC system, and medical toxicologist, and I work at a opioid treatment program. And so I get to see the 360 view of what it looks like when people are coming in, and then, when people are admitted to the hospital, and then when people are actively being treated in recovery. And so let's take it away. Let's do this. I'm really excited to do this and have these conversations. And hopefully we'll be able to make it more conversational. Definitely during my questions, I'm going to ask my fellow presenters to interrupt me and throw in some stories and some ideas that maybe I didn't address or forgot to do.
Sounds good. All right, I will share my screen and get us started.
So, Kat, do you want to tell us a little bit about yourself?
Oh yeah, Kat. Oh, I'm sorry.
Oh, hi. Thanks. Yes, I'm Kat Kaneda, Clinical Project Manager for Bridge. As Nick said, I'll be here dropping down relevant resources as Andy and Ariana demystify misconceptions about buprenorphine. I support implementation of MAT and navigation in California, and previously helped the Learning Collaborative in New York City. So it's a pleasure to be here, and don't hesitate to message me or ask me any questions about any relevant resources.
Awesome. Right. Thank you, Kat. Yes, Kat is our chat ninja, so she's gonna share resources, and thank you so much. All right. Hopefully my screen is, there we go. Can you see my screen?
Yes.
Okay. Now I just need to be able to get myself, sorry, so that I can play. Just a second, sorry about that. All right. Okay, one more time. All right. There we go. All right, so thank you for either being here today or watching and listening. And as Andy said, I'm excited to talk about this just because this is really, and I have to say, Nick and Andy, in my experience, I can talk all day about how to give bup. It's actually not very difficult. When I give buprenorphine in the emergency department, I give a sublingual medication, and I just have to make sure the timing is correct. And that's just like any other medication I give. I'm careful to make sure I have the correct indication and the correct timing. But a lot of these frequently asked questions, I'll say people are frequently afraid to ask, perhaps in chat or live. And yet we do hear these maybe when somebody pulls us aside or when we kind of really get down to why this is a problem. These are the questions that come up. So, and for me, there are no bad questions. I feel like I'm happy to answer them. And I either thought these in the beginning. I practiced for 17 years without giving buprenorphine for opioid withdrawal and have practiced for 5 giving it. So certainly spent more time not giving buprenorphine and having a lot of the same beliefs that I didn't realize at the time were really based in evidence. So again, this is the welcome. We're going to talk about, there's 12 frequently asked questions, and then we'll have some answers. And we really wanted to back up the answers with some evidence. Some of the evidence here we actually will have available in a folder with some articles. And the idea is if let's say you're the evangelist, you're the one who's at your hospital, who's talking about giving buprenorphine, you're going to hear some of this stuff. I hear some of the stuff regularly, and we want you to have the tools in order to dispel all these myths. Because in the end, some of these myths are they're getting in the way of appropriate patient care. So having the publications where you can cite, where you can share with friends, where you can share with colleagues. Maybe your friends aren't as nerdy as mine, so it's probably just colleagues. But this is the stuff that's going to really help you answer a lot of these questions. So our objectives are that we're going to explain that medications are the most effective treatment for opioid use disorder, recall common questions and concerns, compose evidence-based responses to frequently asked questions and concerns, and recognize questions and hesitancy rooted in stigma, support inclusive, welcoming environment for patients with opioid use disorder. And what I can tell you is when we get through this, actually having this information will make your job easier. All right. So let's get into it. And Andy, Nick, same thing. You can interrupt me. You can tell me if you've experienced anything with this frequently asked question. But this is kind of the number one, that I've heard. And this is actually what I said when I was approached with the opportunity to treat with buprenorphine in the emergency department. So is the treatment of opioid use disorder with medication something we should be doing from the ED setting? So this is specifically, I actually said, isn't that illegal? And I said, an emergency department is not the place where we should be treating substance use disorders. We're not a substance use treatment facility. There's treatment facilities out there. So I just first want to share that my first, when I started getting into this, I did not realize the body of evidence out there. It just kind of flew past me. So this is actually a study done by Scott Weiner, who I have great respect for, who studied patients who were treated in Massachusetts specifically for opioid overdose, 2011 to 2015. And what they saw in this study is the huge risk of overdose death within the first year after a non-fatal overdose. This is somebody who leaves the emergency department, we know frequently against medical advice, but also could be discharged from the emergency department. So this is what's important to know, and what's important to cite is that 1 in 20, so 5% of people will die within the first year. And of those who died, 20% died in the first month. And of those that died in the first month, 22% died in the first couple of days. So when you compare this to other, emergency medical problems that we treat, this is really high stakes. This is, we look at heart scores because we know the increased mortality after a visit for chest pain, but we're looking at high mortality in that first year. And I have to emphasize, this is for like 20-year-olds. This is high mortality for 20-year-olds. So I just want to emphasize that treatment from the emergency department setting is essential, and the stakes are really high. So that's why we very much need to practice evidence-based medicine. And the other thing I want to highlight here is that there's an increase in drug-related death after somebody is hospitalized. So if we are not treating in the, and we know we initiate treatment in the emergency department setting, right? We frequently are the quarterbacks. We will start a pathway. So if we are talking about this from the beginning, it's important, but we have a significant increase in drug-related deaths after somebody's hospitalized without treatment. And if you think about it, it's somebody not using in the hospital setting, somebody who's been hospitalized. If we're not treating them, we release them from the hospital. And let's say we're going with the antiquated model of abstinence. I used to think that that was evidence-based, and it's just not. And what we saw is that people die. So we could hospitalize them for an abscess, for endocarditis, but we do see this drug-related death increase after hospitalization. And we really have to consider that. Are we causing harm then if we are hospitalizing somebody without actually treating them? And that increase in drug-related death after hospitalization continues out to a year, we see. So this is really important to note and something to talk about, and really to push not just your emergency department, but make sure your hospital partners are aware of the importance of this. So the other reason the emergency department is such an important place for this work is there's opportunity. So I can tell you the folks that I see, especially the ones who are struggling with opioid use disorder, they're not seeking care elsewhere. So we know that, and this is I think really just the base level, that 17% of patients who are discharged from acute care have a substance use disorder diagnosis, right? Those are the folks who actually receive the diagnosis. I know that in my setting, when I wasn't treating opioid use disorder as a co-occurring illness, I also wasn't diagnosing it. So I would not put this in, if somebody came in with an abscess, I was not giving the diagnosis of opioid use disorder. I might chart something in the chart, but so it's not something that we could capture. Now that I treat it and recognize it easier and actually recognize as a comorbidity, I'm able to address it. And so it's interesting how you can, that this is probably a very much an underestimation. So there's, for every 1,000 people over 15, there's 25 drug-related emergency department visits. So chief complaint is drug-related, but 28% of adult emergency department patients do screen positive for a substance use disorder. So there's a lot of folks that we are missing here that we could be treating and reducing their risk of a lot of things, including overdose. So also reducing their risk of infectious disease, reducing morbidity as well as mortality. So again, we know that I always say, if you just look at your tracking board any one day, so if you're at home or if you're looking at this on shift and you have ability to look at your tracking board, I bet if you take a look, and even if it doesn't look like a substance use disorder issue, you'll probably see, ooh, that actually is related to substance use disorder. So certainly a big opportunity to treat here. And we know that treatment specifically for opioid use disorder with medication decreases all-cause mortality actually by more than 50%. So there's a few different articles here that are cited, but what we know is that when we treat with medication, so medication-assisted treatment, so we're talking about buprenorphine and we're talking about methadone, that we can reduce a person's risk of dying from any cause by more than 50%. So this is just a no-brainer. I remember talking to somebody about this and they said, well, what articles, can you give me some recommendations? And I had them initially, and this was just an exercise so they could see the enormous body of evidence out there, just emergency department, opioid use disorder, and treatment. And they said there's so much. So we have a few cited here just showing that we're going to reduce a person's risk of dying from any cause by giving the right medication. So, and we also know that that we can reduce we have a 10-fold decrease in mortality. This is a 7-year cohort study when somebody's taking buprenorphine. But there's actually a high mortality rate when somebody's not taking buprenorphine. So when folks are, I really want to stress this here, when folks are in and out of treatment, that their risk of dying when they're out of treatment goes up substantially. So I see buprenorphine as a life-saving medication, right? This is evidence-based. But if somebody returns to use, if somebody stops taking buprenorphine, I know the risk of dying is actually pretty high, and there's fentanyl out there and in most of our communities, which is maybe different than what they were using previously. So I'm very intent on getting them back on buprenorphine. So I don't see, when somebody comes back in and is requesting treatment, I'm grateful, because I know their risk of dying from any cause is going to go down by 50%. I know we have a tenfold decrease in mortality, but I also know that their risk out of treatment is actually really high. So I want to make sure to engage them in treatment. I welcome them with open arms. I do not see this as a failure. I see this as a part of the disease process. So that's important. I can tell you in my department, like 74% of my patients, I just took a look, we're actually first-time starts or newly initiated into treatment. But I have about 26% who may have fallen out of treatment and they didn't know where to go. And they came into my emergency department saying, hey, this isn't going well, I need some help. That's a really easy start. That's very easy medicine. These folks are very well aware of buprenorphine, know how to start it, and it's frequently a prescription I can give them, and they can start at home if they're not already in significant withdrawal. Andy, do you have any experience with, like, when you're seeing folks return, have you had any problems getting them back into treatment?
It depends, but most of the time, like when people fall out, it's from a social situation, and most clinics are more than happy to take them back, because we all accept that as kind of a process. It takes a little while to figure out how to hit cruising altitude and get your legs underneath you. And we, when I'm working in a clinic, we see, some patients that'll leave, or we'll lose them for a little bit, and, they'll come back, and we're happy to see them again. And they'll, they're usually, upset about what occurred. And, but can always take that as a learning experience. Like, what was the thing that led you to use again? Like, well, it's usually a stressful situation or death in the family or something like that. Or they, met up with somebody that they used to hang out with, that kind of led to all the, usage later. And so that's good. So, every time they come back, it actually becomes a more powerful interaction, because they learn a lot, they gain a lot of wisdom, and it's actually like very therapeutic and beneficial, to kind of sometimes go through those, as long as they don't die or have something bad happen to them. Like, that's not what we want to have happen, but yeah, for us in our clinics and a lot of places around here, it is easy to enroll in a lot of the programs.
Yeah, and having the emergency department as this entry point back into treatment is really important, because it's visible. People can get there by bus. We usually have bus stops in front of our, the bus really does drop off. Like, I say that, but it really does drop off at the emergency department. And so when somebody, I have so many folks who have this moment where they say, ah, man, I can't believe I did this. Like, I went down this path again. I need to get treatment. And you want that just completely frictionless entry back into treatment because of the risk of dying, right? And so this really gives an opportunity to do that. So
and it makes it easy too, because a lot of clinics only will do, like either Monday through Friday, or like a certain day of the week the doctor is there. And so your ability to be able to bridge them from, any day of the week or any time of the day that they need to come in and restart, that keeps them safe until they can get back to the clinic that they're at before, right? Re-engage with the service that they had. And so, being there for somebody at any time, and them knowing that they can do that, that's a huge thing that you're serving the community.
Yep, agreed. And again, just another, here it's interesting, because this was something published in 2017 where they cited methadone as reducing deaths. And they said, well, we're not sure with buprenorphine. Well, we really actually found that that we were, with buprenorphine specifically in the emergency department setting, we were able to make a big difference. And Sarah Wakeman heroically, she published this in 2020 that looked at a huge cohort of people. This is like, we're talking more than 40,000 people. And we were talking about different treatment pathways for opioid use disorder. And what they did find is there was a 76% decreased risk of overdose at 3 months. And this is with the medication pathway. And this is this is comparing to detoxification. I used to think that detoxification, like this gold standard, was folks being off of everything. That's what I actually thought for 17 years. And unfortunately, that's harmful to folks. So we know that actually being in medication treatment for opioid use disorder reduces that person's risk of dying, reduces that person's risk of overdose. Because you just talked about it, Andy, return to use is it can happen. I mean, there's triggers. Sometimes all I want is a really good cupcake. Like I've had a bad day. Give me that cookie, and so that's the way my brain is wired. And for a lot of folks who have struggled with opioid use disorder or any substance use disorder, there's a wiring there where when there's a high level of stress or there's a trigger that they immediately go to, okay, that drug makes me feel better, right? Give me that drug, and they crave it like crazy. So we can decrease a person's risk of craving. And I talk to my patients. I actually work at an FQHC now. This is really fun work. And so I started doing this in the emergency department, still do this all the time, but I get to work a half day at an FQHC because it's so much fun. And those patients are super stable. They're like, but I talk to them, are you craving? And gosh, I'm seeing some of my patients who's, have somebody they know die from an overdose because of fentanyl. And that can be a trigger for them. So we talk about craving. We make sure they're on the appropriate dose of medication. And again, having the opportunity that if they're craving, if they're thinking about return to use and they're not on medications even, just having the ability to get started right away, making a choice to get back in treatment right away rather than return to use can decrease death. So again, really significant numbers here. And in this Wakeman article, they compared this also to intensive behavioral health treatment. So they just didn't find a difference with intensive behavioral health interventions by themselves. So yes, patients who are treated with behavioral health options who are in treatment with medication do better, but by itself, it was not a very effective pathway by itself. So this is an important thing to look at. Now, Trekzone also, we didn't see a big difference in effectiveness, but with medications, we saw this huge difference in a reduction at overdose. So, all right, I'm gonna turn it over to you, Nick. Let me stop.
Yeah, well, I want to ask a quick question.
Yeah.
Like, is it a deal for the emergency providers to identify life-threatening diseases and not discharge them in an unsafe manner? And that's what we do all the time, right?
Yeah, our whole goal. Yeah, I mean, if you look at
what we do, like a chest pain, we're gonna see is it high risk, is it low risk, can it be discharged? Like we don't want them to follow up, and I'm not trying to be facetious, but like sudden death clinic, like on an outpatient basis, we don't do that with any other disease process, right? Like high risk diseases.
I have to talk heart scores all day long, right? Because we know there's always some risk, right? There's always some risk, but I'm going to risk stratify folks so that I make sure I make a safe discharge, and I chart that. So this is no different. This is something where if you're seeing somebody with opioid use disorder, it's really important to document a conversation about medication
same
treatment.
thought process, different disease. Right.
And really it's, the evidence is out there. So you're going to, I suspect there's going to be more, there's more people are going to be talking about this is the standard of care because the data is so compelling. This is something that is easily done in the emergency department as well. And if you can't give the medication, if you say, hey, listen, there's this, they're not quite in withdrawal yet, it takes 5 minutes to get an ex-waiver to prescribe it. And I can tell you prescribing it is easier a lot of times, especially with folks who are, who know how to start this at home. This is just a prescription. I've given it in the waiting room. But you know what, Andy, I'm glad you bring that up because I always say, picture a world where we say we don't treat chest pain in the emergency department. Sorry, it's just not our thing. Like you need to go see a cardiologist for that. That's too complicated for us in the ED. There's specialists for that. So what would happen, right? Could you imagine what would happen if we didn't treat chest pain in the emergency department? People would just die. So we wouldn't see them. They would just die. Well, guess what's happening with opioid withdrawal? People are just dying, right? People with opioid use disorder are dying from overdoses. So I just think that's important to note that there is reason to consider that, and that's not acceptable. So,
are you also saying too that like we're trying to make it easier for people to access care and treatment, or at least as easy as it is to get heroin or something?
Think about it. When people say, well, aren't people just gonna, are they gonna abuse buprenorphine or are they gonna divert it? Are they just gonna sell it? And I always say, gosh, if we made it, because this is a very safe medication. We've talked about in our previous talks how safe this is. There's a ceiling effect on respiratory depression. I see that if there is a market for buprenorphine out there, that's because we're not making it easy enough to access medicine. So we won't have a diversion problem with buprenorphine if we simply give it to the people who need it. Because when we see it diverted, we see by and large it's used for its intended purpose, which is to treat withdrawal. So I think that's really important to know. Yep. All right, thanks. All right, I'm going to turn it over to you, Nick. Or is it you, Nick, or Andy? Is it Andy next? Oh, yep. Andy, it's your turn.
Yeah. I'll get there. Hold on a second. Bear with me. I can do this. There it is. Can you see this one? Got it? Yeah, and thumbs up.
Yeah, I can see it.
Okay, I'm gonna make my disclosure. I did work till 3 o'clock last night, so I'm feeling a little bit sleepy, but I can do this. I can do this. That's what I was. All right. Isn't starting someone on buprenorphine trading one addiction for another? How often have you all heard this? And you, Nick and Ariana, you can just unmute because I want to have a conversation.
Oh, okay. So this is the first thing I said. I just want you to know, I walked into a room of people who were telling me that I should be giving buprenorphine. I said, that's just trading one opioid for another.
Boom.
Came out of my mouth.
Yeah. And yeah, the things that we say, right? We can make a coffee table book, I think, right on the.
This is the number one thing I get from patients, actually, when I propose starting medications. They're like, nah, I don't want to be on anything. I don't want to trade one thing for another. Or family members. I have had multiple times where family has pulled me out of the room and said, you know, he's on methadone, he's on Suboxone. Can you get him off?
Yep.
That's a really good point, Nick. I always say that actually there's a lot of stigma even within just a community of people who use drugs against medications because of this. Because we need to be able to push this understanding so that people understand, right?
Many of the questions today aren't only from providers. They are things that patients will say often, you know, when I'm trying to treat them.
And we still run into that. Like, you know, I did a clinic yesterday, and a lot of the patients that have a methadone and buprenorphine, you know, we continue to have this discussion. And especially when we do the intakes, that's part of the terminology that we address, like right when they come in, because that's exactly some of the first things that they want to say. Like, I'll be on this, and I just want to, you know, they don't want to detox because, you know, this is just another addiction that I'm treating. It's like, well, some of that's true, it's not. But I think I want to go into, like, you know, why words matter here, and words matter a lot in this space, but definitions I think matter a lot as well when we're describing, you know, the phenomena here that, you know, that we're treating, right? And all these things are very different, and they all need to be understood. The first one is tolerance. The second one is dependence, and the last one is, you know, addiction or substance use disorder. And, you know, you hear this in the lay press, and you hear this from clinicians and patients themselves, and, you know, even people in the you know, addiction community and people that are clinicians there conflate these terms, right? They'll say chemical dependence when they mean, you know, substance use disorder, and these things, you know, need to be pulled apart and addressed appropriately, because it also helps with, like, you know, getting a better idea of what the diagnosis is and like what we're treating and how we're doing it. And again, when you define these terms, I think that helps also reduce the stigma too that's around it too, right? It helps patients identify like what we're doing. So the tolerance means you're taking more substance to get the same effect, right? And we've all seen that tolerance curve that happens, is that you increase the dose to try to get, you know, whatever it is. And it can be from any medication, right? But the idea is that over time, you know, it takes more to get whatever that desired effect is. That's a physiologic idea. Dependence also is a physiologic idea, is that means that your body has developed these counter-regulatory ways to deal with the chronic stimulation of that substance. And so, you know, it's, you know, if you always have alcohol in your system, then your body is going to change the way the receptors are there, right? It's going to downregulate some, it might change some subreceptors. So you can stay awake with an alcohol level of 250 or 300, right? And you can function or do whatever it is. And that's your body doing what it's been designed to do to kind of compensate for that chronic stimulation that you have. And dependence, the sine qua non of dependence, means when you stop that stimulation, the counter regulatory processes that your body has set up now shine through. And you have the withdrawal phenomenon from that. So really just the dependence is physiologic. There's nothing else that has to do with it except the way your body has developed dealing with the chronic stimulation, whatever it is. So for opioids, like if you have dependence and you stop it, then you have withdrawal phenomenon, right? And that can happen for people who are chronically treated for pain. And if they stop an opioid, they're going to have withdrawal syndrome. And same thing for people who have substance use. Now, the difference there is that the substance use causes, physical distress to the person, and it causes this collateral damage. And it's really easy to remember using the C's if you're going through and trying to make the diagnosis of OUD, is that they have lost control. They start using and they just can't stop. And the compulsive use, and then the negative consequences that are associated with it, right? So did they get in trouble with their family, lose job, financial difficulties, legal problems? Are they using in an unsafe way, et cetera? And you can, this is DSM-5 criteria, and really it's just kind of checking the boxes and have any of these things been true for the past 12 months, and then you can make the diagnosis of OUD. And that one, that's where the behaviors come from. That's where a lot of the things that cause judgment occur, right? So that's very different than one versus another. So we also have to go back and define what addiction is too. And this is the ASAM definition, which is it's a treatable chronic medical disease involving complex interactions among brain circuits, genetics, environment, and an individual's life experiences, right? It is really interesting. And Campbell, you're probably running into this a lot, is that when you get people's, experiences through their life, like when they started using and why they started using. And it's just, some of these stories are amazing and very sad.
Yeah, I'm glad you bring that up. I always say I say this in my emergency department all the time. Everybody's got a story. Everybody's got a story. That person that comes in every day, they've got a story, even if they're not in a place to share it. So I think that's important we have to make sure we humanize, right? It's true.
Yeah, and then also make the behaviors that you see kind of, define them in more clinical terms, right? So I'm going to continue with this, is that people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And so some of the behaviors you see, like they're not being mean to you, like take yourself out of the thing. They're doing what they're doing because of the use disorder that they have. And then finally, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And so that's reinforcing the idea that this is a chronic brain disease that needs to be taken care of. So yes, medications that we're using to treat opioid use disorder do have dependence. Again, it's a physiologic phenomenon that if you stop methadone or if you stop buprenorphine, they'll have withdrawal. That is true. And full stop, right? But we use that dependence, and there's safer medications to treat the addiction part, the C's that we were talking about, right? They eliminate the cravings, the compulsive use and consequences, and that's the treatment for this disease process, right? That's it. We're using these theoretical, we're using these principles to treat the disease. So, if the whole point of medicine is to try to keep people healthy and happy and avoiding consequences and not dying, this makes a whole lot of sense to me, right? For buprenorphine, for example, we're given a medication that's highly adherent to the receptor, that even if they tried using something, deadly, that's a full opioid agonist that'll cause respiratory depression and death, it is much harder to do that, right? And it has a safety feature built in that either they won't feel it or they're not going to have the same effect from it because of the, high affinity of buprenorphine. And same thing for methadone. Like if they're not using, drugs as much, straight up, fentanyl and high potency, other things, then they're less likely to die and overdose. And again, they're not experience the cravings because their opioid receptors are being involved, like they're already involved, they're already in a relationship. They're not using, they don't feel the cravings, right? And they can be functional. And so, I just got to say again, is that the people that I saw all day yesterday, they are rock stars. They are rocking it, and they continue to deal with this. Sometimes the cravings, and sometimes when they have a negative mood or emotion, then their brain still tells me, hey, we can still do some drugs and it'll be okay. Like, we'll fix it for a short period of time. But then their job is to take a step back and say, okay, all right, my brain is talking to me, but let's play this forward, and this is not going to end up well. And it's much easier to, avoid and to ignore that voice in your head, that reward circuitry when you're being treated with a medication than when you're not. I think mine's a little bit shorter there, so we'll keep going a little faster. Is this you, Nick?
It's me.
Do it.
I'm going to steal the screen from you.
Steal it.
Oh, it says I can't. You have to stop sharing first.
I do. Do it. This is maybe we should just keep one person on there and then do that. Next slide.
I know we were talking about that. The only thing is the annoying next slide thing. All right. Can you see my full screen? Yeah, good. Okay. If so, frequently asked question. This is usually from the patients. If someone is using opioids, will treating them with Suboxone, which is the combination buprenorphine naloxone medication, cause withdrawal? The reason they're asking this typically is they're alluding to the fact that, of course, opioid withdrawal is the one thing that their life goals are seeking to avoid. And so they're going out and doing these compulsive and potentially dangerous things to avoid opioid withdrawal. And you're proposing to give them a medication that seems to them is going to make them sick, which they don't want. In addition, most patients have tried Suboxone, buprenorphine naloxone medication, on the street. So they get it from friends. Often when I talk to patients, their drug dealer will have Suboxone to give them if their fentanyl supply runs out. And so they've almost always had this before. And if they took it too early because they weren't prescribed it, they weren't guided how to do it, then they went through withdrawal because of buprenorphine precipitated withdrawal, which we'll talk about in a second. But they think it's from the naloxone, which I think makes perfect sense. But this is an opportunity to educate about how the naloxone does not cause withdrawal. And this is important because having naloxone in the medication, so doing the combination, is really important for patient safety and to limit diversion. So we should always be doing the combination strips or tablets. And so convincing them that this is okay is important. And here's how you do it. So what we're talking about is really the bioavailability of a medication based on the route of administration. And so in the case of naloxone, you have 100% bioavailability when it's given IV. But when it's given by mouth, under the tongue, intranasally, the bioavailability changes. And this is true for every medication. It's true for buprenorphine as well. So the interesting thing about the combination of buprenorphine naloxone is that it utilizes the fact that buprenorphine is pretty well absorbed sublingually, but the naloxone is not. So you only get 3% of naloxone to be bioavailable when it's taken sublingually. So sure, it seems like not very much, but why would they want any naloxone at all? Well, let's do a quick example. So most patients are taking 16 milligrams of buprenorphine and 4 milligrams of naloxone. That's the combination standard dose. And so if you do some math, they're going to get about 0.12 milligrams of naloxone. I usually start very small, either 0.4 or 0.04 milligrams of naloxone if someone's breathing shallowly and I want to increase the respiratory rate. But I've seen some opioid withdrawal even with 0.12 milligrams of naloxone. So, I don't think the fact that it's a small dose would convince me that it wouldn't cause the withdrawal they're concerned of. But remember, you're also giving them the buprenorphine. And so there's a wide bioavailability between 25 and 60%. But even that, the range of bioavailable dose is 4 to 9.6 milligrams of buprenorphine that they would get sublingually. And so because buprenorphine is such a potent mu receptor, even if you were to get some withdrawal from naloxone, the buprenorphine is outcompeting the naloxone with this high dose. And so naloxone is essentially inert. It's not going to be causing the withdrawal symptoms. What does cause the withdrawal symptoms is if they were taking a full agonist, such as fentanyl or heroin or morphine, and they had activity up here at the highest level of the curve, and then you gave them buprenorphine, this delta, this change from the full to the partial agonist gives them the sense of withdrawal similar to naloxone, even though it is the buprenorphine that precipitated withdrawal and not the naloxone. So that's the quick reason why naloxone does not cause withdrawal, but buprenorphine can in the dual medication form. So now we have some spaced repetition polling question. So just take a minute. Patients with opioid use disorder are at an elevated risk of overdose at which of the following times? You have A, 24 hours after ED visit for overdose, B, the year following hospitalization for drug treatment, C, while being treated with naltrexone, or D, which is A and B. And the answer I was going for was D. All right.
All right.
Ariana, you're back up.
Okay. Let me. Okay. All right. So next question. And again, this is what I used to do. So I always talk about the list. Nick, Andy, did you ever have the list at your facilities?
I just had the social worker who gave them the list.
Oh, you have more resources than me. So I do have a social worker, and we would call a social worker because we don't have one in the emergency department previously. And they would send me the list. So then I would have copies of the list, and the list would be like askew. But anyway, so on the list was a lot of places that were all about like detoxification and counseling. So the question is, isn't it better to refer patients to counseling first and then start medications after that? Like, do people fix themselves? They fix all their everything first, right? Is that the idea? And then take medications after that. So, like with hypertension, we sometimes will have folks do a dietary change, right? But this is a little different. All right, so this is just, you always have to come back to Gail D'Onofrio, and I love putting her picture up. She's brilliant, and she did have the RCT that we can always go back to. And we're not going to repeat this RCT because this was so compelling. So when they gave at Yale University, they published this in JAMA in 2015, when they were able to give buprenorphine for opioid withdrawal versus referral or like this intensive counseling, they more than doubled a person's likelihood of being in treatment in 1 month. And you'd say, and this is treatment with medication, and you'd say, well, 1 month, what is that? Well, 1 month that's this period of time where somebody is sticking with it. So, we've looked at various things. I look actually at who's in treatment in 1 month. And sometimes it's actually hard to follow that because folks move, folks stabilize, folks will move, they'll get jobs. But we were really able to see through an RCT, this amazing study that showed that just giving the right medication at the right time to the right patient doubles their likelihood of being in a treatment that reduces their risk of dying from any cause by more than 50%. That's compelling. So we also looked at emergency department initiated buprenorphine. This was published in 2017. This was an RCT, but emergency department initiated buprenorphine for opioid dependence with continuation in primary care. And so there was, looked at outcomes with referral to primary care. I don't have any addiction medicine, like addiction psychiatry in my entire county. I think we have 2 psychiatrists who don't see folks with any use disorders. So this is a primary care thing in my county, which is largely rural. So this was important to show that you can increase a person's retention in addiction treatment. They looked at this at 2 months. They didn't really have great data for a long term, and I'm sure there's some confounders here, but during the 2 months interval, there was an increase. When medication was continued in primary care, there was an increase in retention and treatment. And what we do know, so giving medication for addiction treatment, I call it MAT. I know it's medication assisted treatment. We at California Bridge typically call it medication for addiction treatment because it sounds less stigmatizing, right? So we know that treatment with buprenorphine methadone is associated with a 32% relative rate of reduction for serious opioid related acute care use at 3 months. So detox, intensive behavioral health, like I said, this is really important. That all of these were not, this is from Wakeman, were not associated with reduced overdose or were not associated with improved outcomes. So we just have compelling evidence. And again, in Wakeman's article, we include it, we'll send it out, that we were able to make the biggest difference with medications. So, and this is a huge amount of people. These were folks who were insured. So there's sometimes a difference in population, but we were able to see a significant reduction in serious poor outcomes. So, and I do go back to this because we can talk about all of these numbers, we can talk about all of these studies, but, number needed to treat. I look at number needed to treat a lot just because it's a really simplistic way of talking to somebody about, about evidence-based care. And you can go to the NNT, they have different categories in the NNT. This is available just online, but the thing I wanted to show about this in NNT, I always say you just need to treat 2 people to retain in treatment, just 2 people to retain in treatment. So these are folks who are at high risk of not just overdose, but of harms from infectious disease, from, there's increased criminality, so there's increased violent, issues with violent crime, etc. These are folks that we just have to treat 2 to change their life, right? We've talked about dosing before, and we're not going to get into it too much here, but I did want to show that you have to treat, so 1 in 4 with low dose buprenorphine, that's 2 to 6 milligrams, had retention in treatment. 1 in 3 using medium dose, that's 7 to 16. 1 in 2 had that. So for 2, that's high dose buprenorphine treatment, so more greater than or equal to 16 milligrams. And so actually with my patients, I really am trying to get them to 16 milligrams or above, because I know that they will follow up better, they'll stay in treatment. Why? Because they're at the right dose, they're not craving. Like we look at this with any other medical issue. We want to make sure we give folks the right dose. So I do want to make the emphasis here that this is not one of those, well, we're going to treat you with just a little bit of this, you want to make sure the person is not craving. We've actually initiated craving scores in my hospital and my emergency department so that we're able to address craving, not just withdrawal. Like, because somebody may come in and they already went through the withdrawal, but they're craving, they're going to go out and use, they're trying to make a better choice. We'll give them buprenorphine to treat their craving. So again, we want to make sure we're giving them a decent amount though to get those 2. But come on, even with low dose 4, that's a pretty good number needed to treat. We're looking at like aspirin and STEMI. These are like numbers above 50. So this is extremely low number needed to treat to make a difference. All right. And so, yeah, I don't know, Nick and Andy, do you have anything other, like in terms of why we do this? I think that those numbers can help drive home the point, but I'll stop sharing my screen and then we could talk maybe a little bit about fentanyl here, Andy.
You want me to move to fentanyl? Those numbers speak for themselves. There's not much to say about that. Yeah, we can talk a little bit. So, it's just, don't refer just to counseling, make sure you're giving medication. Now, medication with counseling can be helpful, but one more thing I'd like to say while you're bringing up your screen is just that we don't require counseling. So I'm in an FQHC. We have an open door to counseling. But one thing I didn't say in the beginning that I think I need to make a point of is
you don't want to make somebody talk about their past when they're in withdrawal or they're craving. Like they have triggers, right? So we see this as emergency stabilization. So we stabilize with medication and then offer opportunities for growth. So that's just it. You know, you might stabilize, you stabilize somebody with a stroke, and then you give them opportunities so that they can get their life back, right? So we're stabilizing people with opioid withdrawal to reduce their risk of dying. And then we're offering opportunities, just to build up their resilience and identify triggers, et cetera. But we don't require it. I have plenty of people who've been in treatment for years, and they could probably give a lot of us some life lessons. So we don't require that they're getting counseling.
Yeah, counseling can be just like an amazing thing for a lot of people, and it's really helpful. But I think the first thing is, from a physician treatment standpoint, is to like get the physiology under control, right? And then the counseling definitely can add a whole lot to their whole experience. All right, I'm going to use the PDF because the PowerPoint was malaligned last time. I apologize that. But here we go. Here's the next one. With fentanyl use, are patients more likely to experience precipitated withdrawal if provider provides standard or high dose buprenorphine induction? Should we be starting patients with lower doses instead? And so let's get through these questions. So there's
Andy,
concern.
who do you get this question from?
Who do I get this one from? Psychiatrist.
Yeah.
That's like the most common person who's asking about this, and like they become real hesitant about, when we talk about what we're doing and referring patients, there's a lot of concern about this that happens. And I think we get into some reasons why, but yeah. What about you?
Yeah, same thing. This is a question to be, when you're a champion for your site and you go to your P&T committee, you start talking to your addiction team, your psychiatry team, your hospitalist team. They're going to try to change the way that has been shown to work in the emergency department because it's not what they're used to. And so just be aware that there are different ways to do it, and that's okay.
I wanted to comment. So Andy, I actually get this from my patients too.
Oh, yeah.
Yeah, there's word out there, right? That people say, oh, I know I'm on fentanyl now, so I can't get on buprenorphine. So a lot of the stuff that we talk about trickles down, and they get this idea that they can't be in treatment, that they're just like relegated to death because they're using fentanyl, which is, I'm sure you're going to talk about.
We'll get to that. So I think, this one is, and there's still evolving literature, so I got to be straight with everybody here, is that fentanyl precipitated withdrawal. You can precipitate withdrawal with just about any opioid dependence from any opioid, right? So that's just something that we got to say out there. The idea with fentanyl is generally we always think of it or have thought of it as a short acting, full opioid agonist that people would use. But with chronic and then the high dose usage, it does, it's lipophilic and it sits in the body for a while. And then honestly, we do a lot of screens on the patients at the opioid treatment program that I work at, and we see fentanyl hang around for a long time, even after the last usage. And so we can still detect that in the body for a while. It doesn't mean it's actually active. It just means it's being excreted, and we're detecting it. And so those are just a couple of things I wanted to start with. In terms of precipitated withdrawal, you go back and you look at the people who have had a precipitated withdrawal, and then there is a nice review of the evidence here, looking at the risk factors for precipitated withdrawal, because obviously you don't want to do that, and you want to be much more careful in the patients that have higher risk for this. And these would include people who have chronic kidney disease, cirrhosis, and then that makes more sense, right? Like maybe more difficult time eliminating the fentanyl and can hang out in their body, or any opioid in general. And methadone is another one too. So people who are on methadone, again, long-acting medication is going to hang out in the body for a while. And maybe that's higher risk use. Fentanyl is there, and then concomitant benzodiazepines. So those are the risk factors that have put in a review paper. And then we also have to take a look at what the dosing had traditionally been. So if you look at some of the older dosing guidelines and initiating people on buprenorphine, they always start with these small doses. And one of the nurses that's been working in substance use for a long time at the program that I work at, she would just tell these stories, is that they would keep these patients in the waiting room, and it'd be a whole day thing. They would sit in there and then give them a little bit of dose, and they would see how they did, and then give a little bit higher dose. And she said it was a big to do. And so the patients had to essentially set aside 4 to 8 hours to get them started on buprenorphine, and they would just start with these like little tiny doses and then move up from there. And then so that was the question: is that part of it too, or like does the dose affect your risk of having precipitated withdrawal? And so there was a study that I think we're going to go through too that used macro doses and found that the patients that they decided to use macro doses on had a lower rate of precipitated withdrawal. And so just a couple of things. So this is a Herring article from JAMA Network Open in 2021, that they looked at the patients who the clinicians at the time used a higher dose, greater than 12 milligrams at one time for buprenorphine induction versus, the typical, if you have a CASA 8, give 8, that a lot of us, teach. And this was a retrospective chart review. This is a convenient sample of people who are coming in, and it just happened to be, there was no randomization to it. It just happened to be the case that some clinicians use higher doses and some use the standard dose. And they looked at the rate of precipitated withdrawal. And here's a busy slide, so I apologize. And you can get really close to your computer, or just download the slides later and then blow it up as much as you can, or even better, read the site, because it's pretty good. And then so you look at the patients and the doses that they got. So that's up on top, and these are the columns that you have. And then you look down at what the adverse event rates are. And this is by dosing, right? And so you saw the patients that had precipitated withdrawal in the 8 milligram dosing, like there was a fair number of them, and you didn't see the same in the higher doses, like to 10 to 12 or 16 or 20 and 24. There was one case, which they talked about in the paper, that did have precipitated withdrawal, and it was a little bit unclear exactly what happened there. But that's the difference, right? Also notably, I'm going to throw this out there, you didn't see precipitated withdrawal in the 2 to 6 milligram one. And so, that's one idea, is that now, and they had a big discussion about this, toxicologists are talking about this a lot now too, is that there's one of two ways, like either you do a microdosing, which is something that we do frequently for inpatients as we're moving them from one full opioid agonist to buprenorphine. And that works really well. So just like little tiny doses over a period of time, over a couple of days usually. Or like if you're going to start it, just go big, because the idea is that you want to prevent precipitated withdrawal.
Hey, and Andy, can I ask you a question about that?
Go ahead.
So what kind of luck have you had with microdosing? The sticky thing for me is if I'm doing microdosing, I'm telling people to continue to use fentanyl, and that feels wrong. And I think from the emergency department, that feels wrong too. I don't know what your experience though has been. I'd love to hear about it.
Sorry, say that again. Microdosing? You cut off a little bit.
Yeah. From the emergency department. Have you found that it's been effective from the emergency department setting?
No. Well, I mean, I haven't had like a great opportunity to do a lot of microdosing for the ED patients. Usually like a self-start for them. Yeah,
and I think for me, it feels weird to tell somebody to keep using fentanyl and a microdose. So that's where I think I run into problems. I tried this too, and my patients didn't follow up. So, I know some of them were afraid of starting, but I had some trouble with follow-up. So I thought from the emergency department setting, this is tricky. I found cross-tapering with methadone can be helpful. That's a whole nother story, but the microdosing for me was a little difficult. Nick, what about you? Yeah, from the ED setting, What about you, Nick?
Yeah, I think in the addiction literature, there's a lot of buzz about microdosing, but it's all setting dependent, right? And so you're talking about patients who are inpatient, they are in a car accident, opioid use disorder, they're on high doses of fentanyl or hydromorphone, and they're giving microdoses to transition. And if you look at the papers, that's what they're talking about. When someone is in the emergency department with withdrawal already, I'm going big.
Yeah, it's
but
been my experience.
As Andy mentioned, I think this is probably the biggest open question that needs more literature. And
sure.
the possibility that I'm wrong about this is, not zero.
Yeah, that's why I think we have to be open about the evidence that's there, right? And do a little bit of a lit review about like what we're actually talking about. So, that's the idea, is that there's some suggestion that the big doses are, the way to go. It also depends on the person that you're dealing with, right? I mean, a lot of the patients that I see in the Detroit area are older, like they're 60, 70, sometimes 80 years old. And, are those doses right for them, especially with all the other medications that they may or may not be on? But then, at the end of the day too, microdosing, I do this not infrequently from the clinic. And it really is a selective patient, because, you have to be pretty adherent to the dosing regimen that you're having. You have to be very patient to do it. You have to feel comfortable that this person is going to be able to go through and understand and remember where they're at. It's much easier to do it in the hospital setting. And like, honestly, when you do microdosing in the hospital setting, it's beautiful. Oh man, it's beautiful. It's an amazing thing that works really well. And, we even take people off of ventilators by getting them on the buprenorphine. It's quite impressive, because they're on like a high dose fentanyl drip, for example. So
Yeah.
the ideas that we wanted to, throw out here for you.
Mm-hmm. Yeah, I know there's a large scale RCT right now where they check for fentanyl, and the precipitated withdrawal rate, even with fentanyl in their system, was still really low, like 1.6%, right? So I think that's always, because it could seem really scary to do all these things when you're starting bup, but precipitated withdrawal is still really low.
I mean, just be, at the end of the day, it's going to happen. There's going to be a percentage of patients that happens, and you have to be prepared for it. And you also have to prepare the patient. So, we talk about this quite often when we do the teaching, is that it's so important that you have the expectation discussion with the patient, that if it does happen, then that's when you hit them with even bigger doses, right? And I think that's also part of the logic, is like, well, if we're going to be given bigger doses to treat the withdrawal, why not just like blow them up right away? I get that too. But we just want to kind of introduce these two ideas for people. And I think you need to pay attention to their comorbidities and the risk factors. And that's just something to decide, as you're going and approaching the patient. So I think that's it for me. I think those are really interesting questions. There's more on this. And now this is very avant-garde stuff. And so we're excited to be able to present that to you.
Okay. This one, comes from colleagues who are new to this, and it's, how can I trust patients to do a home start safely and appropriately? I think it's one thing to ask emergency providers to give buprenorphine when the patient's there, they can monitor them, but it's a whole nother level to give them a prescription and just say, do this by yourself. So the important things to, I think, recognize is that once you sit down and have a lot of conversations with people that use opioids, I think you'll find, like I have, that they almost have all already taken buprenorphine, right? They've done it by themselves. As I mentioned in my last section, sometimes it didn't go well, so they may be hesitant because they caused buprenorphine precipitated withdrawal if they took it too early. But this is pretty rarely going to be a new medication for the patients we're treating. So that's point number one. Point number two is, so there's a lot of regulation around offices housing buprenorphine products. And so the way that addiction clinics used to do it is they would have a patient in withdrawal. They would give them a prescription for buprenorphine. They would then come back to the office and sit in the waiting room or in their holding room and take doses, small doses typically, until they felt better or obviously did worse. And then they'd be done. That'd be an induction. And obviously this is pretty resource intensive, and we're trying to get more addiction clinics and primary care clinics to do this. And so it's important that in 2009, Lee did a paper that showed that home inductions were very successful. So 89% of the patients were successful, and unfortunately 11% were lost to follow-up. So 90% is not bad. The nice thing is that no one had any severe reactions. 5% had mild or moderate withdrawal with the home induction. But given, I think, the morbidity and mortality of the disease, 5% mild or moderate withdrawal isn't a bad trade-off. So We have research showing that it's safe to do this at home. And I think because of this research, this is largely what your outpatient teams are going to be doing. And so if they can do it, I'm pretty confident we can do it. And the nice thing about home inductions is that it really expands the populations that you can start treatment on. So I used to, when I first started doing this, I just did it for people that were coming in an opioid withdrawal, or they were coming in withdrawal because they had sepsis or endocarditis or an abscess or cellulitis, and they couldn't get their drugs. So I would use it in that way. Now I primarily do home inductions because anyone that I detect has an opioid use disorder, I can talk about buprenorphine and then prescribe if they're not in withdrawal. So it just expands this whole group. So typically your post-overdose patients, they either get Narcan or they don't, but they're rarely in withdrawal by the time I see them. They got Narcan, they're feeling better, their Narcan precipitated withdrawal is usually done. And I can't start them then because they're not in withdrawal. And so then I write a prescription. And really that's it. I'm going to show really quick the California Bridge home induction pathway, because I also give them this form so that they go home with instructions. And then I feel more comfortable because they know what to do.
I do this so often, Nick.
Is the bridge?
I really do. Yeah, I can see it.
The bridge one's coming up. Okay, it's hidden on the screen. I got it. Okay. So this is the California Bridge Self-Start Guide. In Michigan, they have one from the Michigan Opioid Collaborative. There are a couple out there. They start with different doses. Because I'm usually in the camp of macro dosing, I prefer this one, but there are other ones that start at lower doses. So basically, you tell the patient, take some time to yourself, have a safe place, have friends and family around. What I usually say is just wait as long as possible, and when you can no longer take it anymore, then you can go ahead and take your medication. Because there are other pathways that have them calculate their cows or their sows. And I don't know, it seems like if you're having a terrible bout of the flu or opioid withdrawal, it's going to be hard to do these calculations and you're just going to want to take the medicine. But if I just say, hold off as long as possible, it decreases your risk of withdrawal, seems to have gone quite well. And then based on how much opioids you use. So here, if you don't use that many opioids, you can start with 4 milligrams and then start after 8 for the day. And then if you use a lot, you can just start with 16 right away. The reason that this is nice, I think these, the split is nice, is because if you precipitate a little bit withdrawal, the treatment is just more buprenorphine. And so what you kind of do is you just cut to the chase with the people that use a lot, and you just give them that big dose up front, and you can go up to 24 or 32 milligrams. So I write a prescription, usually 8-2 twice a day for 7 days. You can do it all in one dose if you want, and then give them this sheet of paper, explain what to do. They have to sign the Michigan Start Talking form regarding the initiation of opioids, because buprenorphine is an opioid, and then we're done. And we'll talk about some legal stuff in a minute in my next presentation. But I think anyone that has an opioid use disorder, to be truly covered and be good, doing good medicine, you should be documenting your conversation about home start. Say this person was not in withdrawal. I could not do a buprenorphine induction in the emergency department. I offered a home induction and they accepted or they declined. And that needs to be in your chart, I think, of every single patient who has opioid use disorder.
Yeah, it's a really good point, Nick. I try to, if they're not ready, right, even if somebody has an abscess and I say, hey, are you interested in this? I'll do home starts, like even if they didn't come in, and I document. And if they say, nah, I'm not ready for treatment, I'll document harm reduction then, right? So I love that point where because this is so easy to get folks started at home. All right, I'm going to go ahead and share my screen now. Okay. So this one, this one, I have to comment that I think I started here too. Like this felt like, oh, can I be doing this? These people are breaking the law. So yes, so it says people who use drugs are breaking the law. why should we be treating this medically? Like, shouldn't they just be in jail? That's something that I get. And I actually, with law enforcement, sometimes there's some friction that I've had. And it boils down to appropriate education. Actually, a lot of my law enforcement partners have seen the benefits of medication stabilization and are asking how we can do a better job treating in that setting. So I just have to make the point of that. But let's just talk about the rise in opioid overdose deaths, because I think it's a time to look at ourselves. So wave one, in where are we now with opioid overdose deaths? So there was a rise in prescription opioid overdose deaths starting in 1999. I think I've been actually practicing since 1999. So I have seen this all the way through. And it was pain as the fifth vital sign. It was that opioids are very safe. There was actually talk that these long-acting opioids are a better way to go. They're just not addictive. I mean, I think most of us knew that that wasn't the case, but like that didn't feel quite right. But come on, we were all over prescribing. We know that. So then what happened? We were all told, oh, you were prescribing way too much. It was like there was like an opioid prescription for every person in America. And, with I think the peak was about 2009. But then what we saw is, as these commonly prescribed opioids, so we saw this increase in those. And then we started seeing, around the same time that we started saying, hey, maybe we should take a different look at this. Maybe we need to go a different way with opioids. This is excess opioids. No other country in the world is giving this many opioids. What's going on here? We started pulling back a little bit. And then we see this rise in heroin overdose deaths starting in 2010. And then what happened after that? Then we really pulled back on prescribed opioids. We pulled back on how much we were prescribing. We can all look at lots of charts where we signal. You can look at your own county and see how much you've decreased in terms of opioid prescribing. But then what happened? Fentanyl. So the rise in synthetic opioid overdose deaths started in 2013, and we've just seen this skyrocketing, deaths from any opioid since that time. So I show this when we talk about, hey, isn't drug use illegal? Is incarceration the answer? We had a part in this. So to not acknowledge that is harmful. So now let's take a look at the same amount of time when we are pulling back, when we say, oh, we've overprescribed. There's been a lot of opioid prescriptions out there. A lot of folks continued on opioids. And so what are we doing about this? And really the answer for so long has been opioid stewardship. Make sure we appropriately prescribe opioids. And I agree that we have to appropriately prescribe opioids. We have to, make sure that we're prescribing to the right person for the right condition for the right amount of time, having informed conversations with our patients. But look at this. So 2010 to 2014, that same amount of time when we said, hey, folks, we have a problem. Only 11% of patients with opioid use disorder, diagnosed opioid use disorder, were prescribed a medication for opioid use disorder. So you could argue, and this is the issue I want to make a point of, we did not pair our efforts with treatment and providing capacity for treatment. So this is an important thing to acknowledge. And we've talked about this. Andy and Nick have touched on this, and this is just the base of everything. Addiction is not a moral failing. It's a chronic disease that requires medical treatment. And when we treat it medically, it works. So this is really important to acknowledge, because really what I'm seeing go on is we prescribe medications. I know I have a lot of teenagers who are prescribed medication, for example, for shoulder pain or et cetera. And then they come back and they're having a problem with getting off of them. They were cut off at some point and they went to street drugs. And now we treat them as if they're a moral failure, rather than actually acknowledging, number one, we had a part in that. Number two, we have treatment that works. So this is really the base of everything. So I really want to drive this home that this is important. And I want to back it up with some evidence here. So let's look at opioid overdose deaths from 2010. We're looking at the same period of time, 2010 to 2020. You can see that, we saw this 44% decrease in opioid prescriptions. These are just in prescriptions, right? Since 2011, a lot of us have decreased how much we're prescribing. I used to routinely give 20 to 30 Norcos, and now I give like 4 to 6. So it's much, much different. But we all, what we saw as opioid prescriptions decreased is that overdose deaths increased. This is very important to acknowledge. So why did this happen? Well, I can tell you right now, we're living the worst case scenario. So there's this massive sustained exposure to the US, to our folks in the US, to opioids. And then we have very abruptly regulated, restricted opioid prescribing. We're gonna be more mindful of how we prescribe these medications. We're gonna look at this, but we did not treat either the dependency. Not all folks were were addicted to their opioids, right? Many were using as prescribed, were prescribed a large amount, but it doesn't mean that this was causing problems in their life. And then we highly restricted this, and we did not pair this with treatment. And so what happened, right? Why are we having a fentanyl crisis? Because somebody else figured this out. So organized crime filled that vacuum with fentanyl and methamphetamine. Sorry, my Siri's talking. So I just want to acknowledge that that's an important part of it. We were a part of it, and it's important to pair any opioid stewardship efforts with treatment as well.
Campbell, I think it's always fun to talk about, the history being rewritten, and if it's always going to repeat itself, because you see all these correlations with prohibition, right?
Mm-hmm.
Like what happened when alcohol was outlawed. Did organized crime fill the vacuum with like light beer, 4%?
Indeed.
White lightning.
That's a good analogy, Andy.
Right. Yeah. And then you talk about the other stuff that got put in there. I was just, doing a talk on organophosphates, and, people were trying to drink this Jamaican ginger, and one of the ingredients that was put in there was called TOCP, that caused a pretty significant neuropathy, and, tens of thousands of people were affected by this. That was put in there, so people could drink still, because it was prohibited, and, developed like a chronic debility and abnormal gait. And it was, the people who were drinking probably were lower socioeconomic status and fairly hit with this disease process because of, that kind of thing, right? You're pulling the rug out from someone, or you're pulling the football away from Charlie Brown. Like, what's going to happen?
Yeah, it's really important to acknowledge. It's like, when somebody approached me about treating with buprenorphine in the emergency department, I said a lot of these things. And I actually did take a moment to just look at myself. And I said, what am I doing right now that I'm so proud of, that I'm like sticking with, right? What was I doing that I was just, I had at the time initiated an entire program to objectively look for opioid use disorder. And I hadn't paired it with treatment. And when I started asking folks like, okay, so if we identify people, now what do we do?
Yeah.
It was like crickets. Nobody had an answer, right? And so I think it's important to acknowledge that, like, yeah, exactly what you're saying. If we don't do it, somebody else is going to. And somebody else found a really good way to make money off of it with a very cheap drug that's easy to transport into the US and easy for people to use. And we did not pair that with easy access to treatment. So another example is, it's much less lethal, but still I'm having a lot of issues with it. I don't know if you are seeing Kratom. Kratom is available at 7-Eleven. So it's like there was one Kratom product called Be Well or something. It was like, Be Well. And it's at 7-Eleven. People don't know it's an opioid. And I have folks who are using to the tune of, several $100 to $1,000 a month using this to be well. And I have to treat them with buprenorphine. So we haven't filled that vacuum with enough evidence-based medical treatment that we know is effective and safe. So yeah, so thank you for that.
Okay, next part. What is the best way to treat acute pain for patients on MOUD? Let's get into this. I'm gonna throw this out there too with the evidence. There's no RCTs. And there's, this is all kind of patient-centered care. And we do this a lot, like on our inpatient consult service. This is one of the more common things that we'll end up doing. is get a consult for someone who has like an acutely painful condition, like a trauma or unplanned surgery issue, or what have you. And they either happen to be on MOUD, or it's one of those things that they happen to be on heroin, and we like to transition them to something better for them, especially when we make the connection at discharge. The usual tenets that we'll do is, maximize alternatives to opioids when you can, right? Like there's a lot of different ways that pain is transmitted through the body. There's a lot of different receptors you can utilize. And just multimodal is great, right? Just careful for drug-drug interactions. Being a toxicologist, like it's a very sensitive thing for me, but there's a lot of ways and safe ways and good medications that can help take some of that out there. Again, it's patient dependent and situation dependent. So, there's a lot of things to pay attention to. If someone's on buprenorphine, depending on what they're coming in with, the analgesic effect lasts for a couple of hours. And so one of the easier things to do is either, split their dose, or just, split and increase their dose. And so instead of just like the 2 a day that might be on, we might move it to like, 4Q, 4 hours, something like that. And that in some patients do really well, like, acute, femur fractures, for example, we've taken care of, like, multi-trauma situations where they didn't want to have anything else, and we just switched their buprenorphine dose, and they were awesome. They watched daytime television like it was their job, which it was for a couple of days till they got better and got out of the hospital. Another thing that we can do too, depending on what's going on, is you can reduce the buprenorphine dose. And so like I like to think of it in my head is you take all of the receptors and you kind of smush it into a circle. And then, a small amount of those receptors you can occupy with buprenorphine. And then the rest you can use that are free, theoretically, to use with the full opioid agonist. So you can do that, but you didn't, take the bup out of the situation. You still got your foot in the door. And so that makes it so much easier that when the acute painful condition resolves, you can just restart buprenorphine very quickly and not have any issues with it. The third option that we've had to run into sometimes, and sometimes this is forced on us by the primary service, is that, we'll come in like a day or two later after they're like, oh yeah, we should maybe call them. And they'll have stopped buprenorphine, and that's okay too, because if they're hospitalized and they're going to be there for a little while, that gives us the option to do the microinduction, which again works beautifully once their acute painful condition is under control. So those are the 3 typical ways that we'll deal with acute pain when someone comes in on buprenorphine products. Methadone is another real common one that we see. Again, it doesn't show up on maps. If they're being treated for OUD, the methadone doesn't show on maps. And so that's just one common thing that I think it's worth remembering. You want to confirm the dose from the clinic they're going to, right? Like, what is their dose? And that's a great baseline. Just continue that dose. What you could do also, same deal with buprenorphine, is that the analgesia effect doesn't last for as long as, the treatment for opioid use disorder. And so you can split up their dose, and that can help a little bit just to help with analgesia on top of the alternatives to opioid therapy. And sometimes that works well. But then you can also just use other opioids as needed. And sometimes, depending on their tolerance, they might need higher doses, and that's okay. You have to, we talk with the clinicians and we give them permission to use full opioid agonists, number one, that they're going to be okay. And secondly, that they may need to use higher doses than they normally are used to. Again, and you have to discuss with them, like, their tolerance is pretty high. They're going to be okay. And just to throw that out there too, is that, there's a lot of people on methadone that still use, heroin, and with the fentanyl in there, I don't even want to know, or I don't even know how to calculate the morphine milligram equivalents that they're taking, and they're doing fine, right? And they're living, outside of the hospital and doing just fine. And so, you have to be okay with the medications that you're giving in an observed way is going to be way safer than what they're doing, and they're going to be okay. And if you take a look at a lot of these review articles that are being written actually by hospitalists and internists and anesthesia, this literature, is pretty consistent with these recommendations. Again, no RCTs on this stuff, but it's just best practice. And it's anecdotally what works very well when we, see patients on these various medications. Now, Trekzone's a little bit different. They'll either have like a necklace or an armband and saying that they're on naltrexone, and that seems a little bit more difficult to deal with, if they have a unplanned, painful process, whatever that might be, trauma, for example. Because now they have naltrexone sitting on the receptors. And so, if you need to overcome that blockade, because naltrexone is, highly, has high affinity for the opioid receptor, you're going to need much higher doses of opioids if you're going to use that to get over the blockade. But again, really stressing the multimodal pain management, including, regional anesthesia blocks when you can, using things, like steroids, lidocaine infusions, like that's all there for you to take a look at. So really just sort of focus on that as best you can. And then sometimes you have to wait out some of the naltrexone or just, use the higher doses to outcompete the naltrexone of opioids. Again, higher affinity stuff like hydromorphone or fentanyl may be required depending on what the process is. And so, honestly, I haven't run into a whole lot of naltrexone patients that we've had to do this for. And then the one that we did have, were the ketamine and regional anesthesia worked really well, and the alternatives worked really well and did fine, and was really committed to not having any exposure to opioids. And I think, that mindset helped a lot with that patient. So at the end of the day, it's most important to be aggressive and be open with the patient, and sometimes be real open that, these are the various options that we've done for other people. There's not a one size fits all. Like, what do you think works best for them, and engage them in the decision-making process and say, like, if this is not working, then we're definitely going to try something else, right? We're going to advocate for you, because at the end of the day, like, what would happen? If they're having pain, like, just imagine this too, you're stuck in the hospital. You don't know what's going to happen, when it's going to happen. You're essentially incarcerated. So that's like a highly anxious situation at baseline. It's boring, and you're stuck watching daytime television again, which is torturous for a lot of people. And you really, need to take that into account too. And it's really easy for people, if they're sort of, cornered or stuck and suffering and in pain, they're going to try to escape that situation. And that means they're going to leave against medical advice. And we see, I think one of the first slides that Campbell put up was awesome to remind us, like, how dangerous it is for patients with substance use disorders to be discharged from the hospital. Because I don't know what percentage of those patients, I got to look at that paper, honestly, that looked like a great graph to dig into, but what percentage of those papers were patients left AMA, and how many of them were not assessed and treated appropriately for their disorder while they were in the hospital. And, you can just imagine how this goes to poor outcomes, right? So it's like, well, you can give them some hydromorphone and keep them in the hospital, and do the surgeries that you got to do, or treat them for endocarditis, or you can make them suffer and they're going to go leave, and like they're going to come back in a worse state. Like, doctor, what do you think is the best thing for this patient? And then when you reflect it that way, and I do it in a much nicer way, but when you reflect it to them that way, play forward with them, it becomes quite clear about how you can do it. Because, no matter what dose of full opioid agonists are on, like, we can always microdose someone onto buprenorphine. They do just fine. Like that, it's okay, right? So that's it. So, and the next thing is I'm gonna let Nick do this one, because this is his stuff. Pull it up, man. This is you.
All right. For those on Bupe, which strategy is appropriate to manage acute pain? Do you like option A, which is split and increase the Bupe dose? B, increase Bupe dose and use small doses of full agonists, such as fentanyl or hydromorphone. C, stop the Bupe, microdose while on full agonists to get patients back on Bupe. Or D, none of the above. I have A. All right, Andy, I'm gonna take your screen over if you stop sharing. All right, this one will be fun. haven't done this before, so we'll go through this. So one thing I've heard, never directly, but usually from like the case manager or social worker, if I have people I'm working with that aren't on board yet, and they ask them, hey, maybe this person's good for bup, and they will say, am I at medical legal risk if I provide someone who uses opioids with a prescription for buprenorphine, which you know is an opioid, and the patient doesn't adhere to the treatment plan? So I've heard this, and I think they're really getting at two separate concerns. Number one is that maybe this person who has a history of drug use is going to keep using their fentanyl, they're going to fill the buprenorphine, they're going to sell it. And so what you're doing then is you are fostering illegal activity by providing buprenorphine to a patient with an opioid use disorder. But what we know is that if you're using illicit buprenorphine, it's as I kind of described previously, you're using it to maintain abstinence from other opioids. So it's typically not used in an abusive way. The overdose death rate from buprenorphine is quite low. Of course, in children and in the elderly, it can be higher because of their respiratory sensitivities. But it's not like fentanyl where there's this high rate of overdose. So the consequences of using buprenorphine illicitly are quite low. It's usually used for people who are trying to stop using heroin or fentanyl. And it usually means that there is a gap between the community's need for buprenorphine and access to adequate treatment. So in general, people would prefer to have it prescribed, but they're having difficulty getting access because sometimes healthcare can be challenging to navigate. So I think that concern is kind of unfounded. Number two is this person has a history of opioid use. We know that they're at risk for opioid overdose. What if I prescribe the opioid, the buprenorphine, that they are then going to die on? Am I going to be in trouble if that happens? And the important thing to know is that, again, rates of overdose deaths from buprenorphine is extremely low, even at high doses. If they're co-ingesting with benzodiazepines or sedatives, the rate does go up. But the graph here shows that with extended doses of buprenorphine, so you can even get further out in this graph, and this ceiling effect persists. Their minute ventilation does not decrease even at high doses, and so they will be somnolent or sedated, but they keep breathing, which makes it a very safe medication for this. On the other hand, untreated opioid use disorder has contributed to approximately 800,000 deaths in the US in about the last year. We know that the 1 year mortality for someone seeking care in the ED after an overdose is 5%, making this a highly morbid and high mortality condition. And so knowing this, in addition to knowing that ASAP guidelines and the AAEM has a white position paper suggesting that we do implement these programs, provide medications to our patients, and give them a prescription until follow-up can be attained, I actually want to emphasize that I think that there's pretty significant medical legal risk by not providing medications for opioid use disorder in our patients. For some of us, it may seem like a weird thing for us, or that we're the only ones doing it, but that may be true regionally. But when you look nationally, buprenorphine from the emergency department has exploded. There were 12.3 prescriptions per 100,000 visits in 2002, and more than 3 times that amount now in 2017. Remember, the NAFRO paper was published in 2015, and so I think a lot of this work has been done between 2017 and 2022. And so I don't know what the current rates of prescriptions are, but it has to be much higher than what it was in 2017. So you are not alone. And I think Ariana has alluded to standard of care several times, and that can be a bit tricky to really pin down. But I do want to bring up the reason I do think that there's risks to all of us and your emergency department if you don't have a pathway for treating people with buprenorphine. So this is a 65-page report from the Legal Action Center, which describes how hospitals and emergency departments are violating federal law by denying required care for substance use disorder. The 2-sentence summary is that hospitals could be liable for violations of the Emergency Medical Treatment and Labor Act, so EMTALA, and the Americans with Disabilities Act and Rehabilitation Act of 1973 and Title VI of the Civil Rights Act of 1964 when they fail to adopt evidence-based practices resulting in patient harm. So they lay this out page by page about how basically they have a case against anyone that doesn't treat people with buprenorphine. Now, as far as I know, no emergency department or physician has yet to be sued or successfully sued. But I do want to share a quick list of lawsuits regarding medications for opioid use disorder that have been successful, and kind of highlights why we should be nervous if we aren't doing this. So let me switch my screens. So I want to present this independently, kind of for effect, because it's a long document. So these are all the cases involving discrimination based on treatment for medication with medications for opioid use disorder. So the jails and prisons are getting hammered right now, and we've heard this from the state as well, that they have traditionally withheld medications from patients, and they have been sued in Massachusetts. What's ME? I think that's Maine, right? Washington, all over the country, North Dakota, and New York. And the people on medications have won, and essentially they have been required to provide them medication while incarcerated. There are more jails, prisons, probation and parole. Now there's a whole set of discrimination cases against those who did not hire people on medications. And that ultimately, so these previous ones, they just had to change their protocols and make them give medications in the incarcerated setting. The employment, there were monetary fines, so $85,000 for discrimination. They had to hire the applicant and they had to implement policy changes. There's $50,000 here. There is $42,000 to 2 people here. And so 80,000 here. So this is expensive. And then in healthcare, there have been a couple regarding so skilled nursing facilities who were declining access to patients on medications. And so civil monetary policies as high as $60,000. Mass Gen was sued because they did not allow patients on medications for opioid use disorder to get a lung transplant. That was a $250,000 settlement, or not settlement, but award. And then there was an orthopedic group that wouldn't do surgeries on people on medications. And so they had to adopt a non-discrimination policy. They had a settlement and had to pay each of the complaints for $15,000. So in other areas, including medicine, there is pretty robust reason to be concerned that if we're not providing medications, it could get us in trouble. And so I did want to, I guess, flip that question on its head, and that I don't think there's any risk to providing medications for opioid use disorder. I do think there is a significant risk if you're not. And every patient with an opioid use disorder should have a brief description in the chart about what you offered, if they accepted or declined, and what other harm reduction strategies you offered during your care for them.
Great place for dot phrases, right?
All right, let me share my screen. I'm going to go through my part pretty quickly here, because we're getting into really I think some of the mechanics and some quick things that I can go through. So the last few FAQs here. Here's a question: can we start a treatment pathway without a screening protocol or question? And the answer is a resounding yes. So I just, that's a simple answer. Drop the mic, move it to Andy. But here, I'll just go through a couple of things. There is a consensus recommendations. This is from the folks at ACEP on the treatment of opioid use disorder in the emergency department. And I can tell you that what is not included in here is that everybody needs a screening question first. So, so there's a lot of recommendations, but again, I've been had my program for 5 years, and we just changed. If I added a screening question to triage, my nurses would, I would be harmed by them. So we did take one very meaningless screening question away, and we made it with better language to make folks feel comfortable with disclosing to us that they have a use disorder, and so that we could capture more people. But again, here's the article from Kate Hawk and folks. And again, when we're talking about implementing best recommendations for starting an emergency department program, you do not need a screening question to get started here. So I also want to make a note of this. Like, there is Andy knows I always mention the French field experience. So I do this because they didn't require a screening question first to give bup. Sometimes we make things too difficult. They actually, in France, they were experiencing a significant increase in HIV and overdose. And so they made buprenorphine actually readily available in pharmacies. So you didn't need a screening question. You didn't need to go have some lengthy evaluation. You just needed to say, I have opioid use disorder, go to a pharmacy and they can get you buprenorphine on the spot. And so what did they see when that happened? They the dark line is heroin overdoses went down, and that light gray line that's as patients were given more buprenorphine. So I want to make that point that this did not require any fancy screening questions. So bottom line here, just make it safe for folks to disclose that they have a use disorder. That's going to be your most powerful tool. Screening questions, though we want to certainly make folks feel comfortable. We want to screen so that we can address people's needs. I understand that. There is a NIDA 1 question quick screen. We use that and sort of amended it to make it more relevant to our patients. But we just put, this is the first sign you see when you walk into my department is, are you using pain pills or heroin? We can help. That's it. So we make it safe. We actually have little flyers like this all over my department in patients' rooms. And the idea is that folks will feel safe disclosing to us they have a use disorder. And not only has this made it safe for folks to disclose to us, it's made my job easier, because rather than somebody coming in really sweaty with abdominal pain, needing, and I have to figure out if they have opioid use disorder, I'm able to, they just tell me and then I treat them. It's really easy. So it's made my job very easy. The diagnosis very easy. So you do not need a screening question in EPIC or in Cerner. You just need to make it safe for folks to disclose it to you. All right. I will stop sharing. Move on to you.
Is that what you're saying?
What did you say?
We got to be more like France.
You gotta be more like France. Yeah, we don't have to, let's not make things more complicated than they need to be. Just make folks feel safe in disclosing.
Would you like some buprenorphine? But of course. So how about this one? Can I give buprenorphine in the ED even if I don't have an X waiver? This one's pretty easy. So we're gonna pull up the CFR, the Code of Federal Regulations. Nothing in this section shall prohibit a physician who is not specifically registered to conduct a narcotic treatment program from administering, but not prescribing, narcotic drugs to a person for the purpose of relieving acute withdrawal symptoms when necessary, while arrangements are being made for referral for the patient. Not more than 1 day's medication may be administered to the person for the person's use at one time. Such emergency treatments may be carried out for not more than 3 days. They may not be renewed or extended. That's directly from the government. So, I mean, short answer is that was a lot of words. It's just a lot of, yes, that's it. You absolutely can. And, while you're in the hospital, when you're ED, you can do it. Well, that's it. You can't prescribe. And this is the one thing that I do run into with residents quite often is that, you have to have a notice of intent, you have to have your X waiver, you have to have an independent DEA. All those things have to be necessary before you can actually prescribe buprenorphine, but that doesn't mean that you can't give it. And that's a frequent misunderstanding that we'll see, like residents will write this prescription out or for 3 days, like, oh, but I can do it for only 3 days, right? It's the prescription part. Definitely give it in the hospital, definitely give it in the emergency department. The script isn't going to happen unless you are, you have your notice of intent. And it's really easy to do. So I put that up there, and I'm sure it's going to go in the chat and any other additional resources. It is so easy. It takes just a little while to do. And it's like just a small time investment for a huge return on investment here for your patients. But at the end of the day, if you don't have anybody, then you can always give large doses that can last them for longer, right? Try to get them through the weekend or what have you until they get to the next appointment. Or patients, that's what the 3-day rule is, they can return for additional doses, for 3 days in a row until they can make arrangements, right? And so, this is just a article that describes like why the big dose can last longer. And I think Nick does this with some frequency, right? Like you get the big doses to try to get people through. And that's it. Yes.
I don't do the 32 milligrams all that much. I've been looking for an opportunity to do it. Like if someone were going to a jail and I didn't think they would get, then I probably would, but I really haven't had that experience. But I'm open to it. It's just usually I just give them the 16 and they get medications for the next couple of days.
Is that you can prescribe, so you just don't have to.
Right.
Yeah, that's how I feel. But before I was actually regularly prescribing for my ED, I would get bigger doses. And Nick, to your point, I give it for patients who are going to jail all the time. Or if somebody's just like, I think they're going to have a problem picking up the prescription for whatever reason. But yeah, I do the same thing as you.
Load them up. All right, here is the California Bridge Guide and guidelines for administration of buprenorphine for treating OUD. And last one.
This is our last one, and then we'll have some frequently asked or some questions from the audience if they're present, or we can chat, and then we'll be done. All right. Is there a way to treat someone in naloxone precipitated withdrawal? I always joked in some of our previous presentations, they had cases and they had questions, and the answer to every single one was buprenorphine. And I think it is true that when the condition is an opioid withdrawal syndrome, the answer is always buprenorphine. So whether it's native withdrawal from fentanyl or heroin, it's buprenorphine. If it's buprenorphine precipitated withdrawal, it's just more buprenorphine. If it's naloxone precipitated withdrawal, it's still buprenorphine. So it's a way to keep it simple. But if you have a patient that came in, right off the street from EMS and is sweaty and throwing up and looking terrible, but they have a state of mind in which they can agree to receive medications, and they want to start buprenorphine, then you just give them a big dose of buprenorphine and it'll relieve some of their naloxone precipitated withdrawal. The nice thing is that when I've done this a handful of times, they're usually very receptive, right? They're kind of in a vulnerable spot. They're feeling terrible. Sometimes people are hesitant to start buprenorphine. That has not been my experience. When they're sick with naloxone, they want buprenorphine as quickly as possible. So make them feel better. And then the trick is, then they're on it, right? So once they're feeling better, your induction's done. You made them feel better from withdrawal. They're on buprenorphine. And once they feel better, you can have a discussion about prescription and follow-up. If they say, I feel better from my naloxone precipitated withdrawal, I don't really want to continue the buprenorphine, I just wanted to get better from that. Well, you've protected them from overdose to a pretty significant degree for about 24 hours. And we know that people that overdose have a high rate of overdose death in the next 24 to 48 hours. And so, it just wins all around when it comes to transitioning from a naloxone precipitated withdrawal to buprenorphine. Here is the California guide about how to do it. In general, if they're taking other sedatives, if you think they're on a bunch of benzos, you don't want to do it, because remember, if you're on buprenorphine plus benzos, you have a high risk of overdose and respiratory depression. You don't want to do it if they're altered to the point that they can't give you consent to treat them. You probably don't want to do it if they're on methadone. Methadone overdose needs to be observed probably in the hospital, potentially Narcan drip, and it can cause precipitated withdrawal for a longer period of time if you do that. So there are reasons to not do it, but if those reasons don't exist, they have some withdrawal. See, the opioid withdrawal scale is less. So typically you want to do 8 or above. And for this, just some withdrawal has to be present. So 4 or above. And then are they agreeable? And then you give them a big dose. So 16 milligrams, because remember, you're competing with a high affinity from naloxone. You observe probably for 2 hours or so, and then prescribe as necessary. So that's it. We have a quick Q&A, and then there's a polling question after our Q&A, and we should still be able to finish right around noon. I'm going to, well, I guess I'll keep sharing because that way we can go to the polling question. So for our audience members, do you guys have any questions about what we talked about today? If not, that's okay. Does anyone from the presenting team or from the MOP or MHA want to chime in with any questions or thoughts?
No, I was just going to say, I think with all of these FAQs, I think the big intention here is just, you're going to hear some of this stuff. And I think I appreciate, Nick, that it's like, who does it come from? There's different people that will have different questions here. And just having these resources at the ready to say, you know what, actually, here's what's really going on, or here's what you can really do. I think that's important. So I keep I keep a little file of stuff so I can quickly respond and quash some of the myths that are out there when they do come up. And 5 years in, they still come up sometimes. So, and I don't shame anybody. Like there's, I start in the same place. It's just bringing people along. So, Nick, I think knowing who's the person asking the question is important. So I think that's my only thing. And don't be afraid to ask if you have a question here. You don't have to say it a certain way or perfectly. You could just ask it, and we're on board to help move things along. If there's something that you feel like is this compelling question that you just aren't sure.
I wanted you two to ask the question that I sometimes ask myself in moments of self-doubt, which is throughout the history of, I guess, the 20th century and with opioids, you had, what was first? Heroin was first, and then morphine was created to treat heroin use disorder, and that was marketed as the cure. And then it was OxyContin, oxycodone, that was for chronic pain that couldn't be addictive. And so it's been generation after generation of medications. Why is buprenorphine any different than what they were trying to do then?
I mean, I could start, and Andy, maybe you could take it from there. I've thought this, I have my, we have our moments where we think, what am I doing different than other people have done before? And then I say, oh, you know what? This is a generic medication that's been around forever. This is a partial opioid agonist. So it has a ceiling effect on respiratory, depression. So it's a different animal, right? And I'm not, there's so much evidence out there that's been developed over a matter of years. So I say I was an early adopter. I wasn't really. The evidence was all there when I started doing this. So unfortunately, we waited so long that the evidence is just glaring now for this. But I also say, if there was something better that came along, then I would certainly do that. This is all about, medical practice changes, medical practice evolves. The stuff that we do evolves. So what we do is we do the best thing with the best evidence at the time, and constantly take a look and make sure that we're doing good and not doing harm, right? So I think having that open view is really important, and knowing that this is the best thing we have right now. And we're hoping that as things move forward, maybe there's something better that comes along. But that's, so rooting it in humility, but also going with the evidence and knowing that that's just how we practice medicine. I don't know. What about you, Andy?
I think part of this discussion too is getting better as clinicians to understand use disorders better as well, right? For a long time, House of Medicine ignored it or penalized people, or it was not a part of something that we took care of. And normalizing this and seeing it as a chronic disease process, right? And the effectiveness of the treatment and stop the therapeutic nihilism, right? That's the other important part of it, right? Because the better that medicine accepts this as just like normal part of therapy that you're going to see, that you're going to take care of, like that just trickles throughout. And so I think that's one of the differences that you also know too, right? When you start opening people up to this, being like, oh, okay, that's easy. And that's doable. And we just haven't done that. And that's one of the differences too, that we see. Oh, we have a guest speaker.
Yeah, we do have a guest speaker.
That's not fair. But that's the only thing that I would add. Right? The progression, that we have been talking about, the interest, the progression of the science that's behind this too. There's a lot of smart people that are working on this, and that's super exciting as well. Normalizing it, a lot more science, industry evidence that is accumulating, which hasn't happened before in history as well.
Perfect. Thank you for, yeah, I agree. I think what I come back to is the pharmacology is just different. Like buprenorphine is just very safe, and there's a lot of evidence. And as you guys have mentioned, I think it is a whole different thing. All right. Polling question. Last one. If someone is in an naloxone precipitated withdrawal with a withdrawal scale greater than 4, the first dose of bup 1 would provide is it A, the 2-0.5 milligram dose. So that's the 2 milligrams of buprenorphine and the 0.5 of naloxone, or 4-1, 8-2, 16-4. Which one would you do? Yeah, with the bridge pathway is 16-4. I think in general, you're going to want to err on the side of a higher dose. Buprenorphine is often odd, but one way that it's odd is that typically higher doses are going to be safer in that they, in this case, make people stop withdrawing from naloxone, and very rarely do they cause respiratory depression. And so this is a situation where erring high is better than erring too low. Okay. That's all we have for you. I do want to thank everyone who came today, plus everyone who's listening at a later date. There's a lot of work by the Michigan Opioid Partnership team and California Bridge. I know Marissa's been in the waiting room and chat, is very instrumental in developing all of these talks and organizing all of us. So thank you, Marissa, and thank you to Kat and Andy and Ariana. It's been fun.
Thank you, everybody.
Thank you.
Thanks for your chat ninja skills, Kat.